Okay, so the next module is going to be for distal radius fracture, shorthand DRF. Again, just a crash course, not going to go super in depth, especially with this one. There's so many rabbit holes you can find yourself going into. So many things you can do, so many things to consider. But this is a fun condition to treat, in my opinion. But let's dive into it. So, like other modules, similar format, what it is, how does it happen, how do patients usually feel, anatomically, what is causing these symptoms, looking briefly into the evaluation and treatment, and in this one specifically, will follow kind of like a protocol based on surgical intervention. But just know that not everybody who undergoes DRF has a surgery done. Some people go with a conservative approach. Some people go with the ORIF approach, but that will be in your eval notes. And if not, you'll ask the patient. They'll know if they had a surgery or not, but you'll use that for your timeline. So let's get into it. So with the introduction, so what and how? So really it's really interesting. So DRFs is very, very common, unfortunately. There's about like 150,000 or 200,000 annually. So in a straightforward way, DRF is a fracture that occurs on the distal end of the radius. And so common symptoms associated with this is pain around the wrist, especially with movement, swelling, tenderness, deformity, misalignment of the wrist, bruising, and just really overall limited mobility and strength. So grip and pinch. I believe there's about seven recognized types of distal radius fractures within like a eponym essentially, but however, the two most common are Cole's fracture and Smith fracture. So essentially, Cole's fracture, and you can follow along with me on the image on the right, is a dorsally displaced extra-articular fracture, whereas Smith fracture is volarly displaced. Like I said, two most common just based on the anatomy of the radius, but just know that there's different ways that it can fracture. It'll often be in the notes, just something to consider. So really, essentially the difference between these two fractures is the direction in which the distal end of the radius bone is pushed towards when it is fractured. So for example, if the distal end of the radius is displaced dorsally, so like from the back of the hand, it is considered to be a Coles fracture. And if the distal end of the radius is displaced volarly, then it's considered to be a Smith fracture, as seen in the image. It is useful to note that the Coles fracture is the most common, as it occurs usually when an individual is falling on an outstretched hand, or my favorite acronym, FOOSH. Um, but the individual breaks their fall by stopping themselves using the palm of their hand. So kind of like a reflex, in all honesty. If you were to fall, you kind of want to catch yourself with your hand, and that extended arm and the impact of it can fracture that distal radius right there. The Smith fracture, however, often occurs when the individual falls on an outstretched hand. However, that the wrist is in flexion, causing them to fall on a bent wrist rather than their palm. So that's just kind of a little caveat there. So let's talk about your patient. So while the patient may have fractured their distal radius, range of motion is still affected at the forearm, the wrist, at the hand level. Patients will often come into the first therapy visit feeling very stiff, tight, and discuss various functional limitations. Grip strength is decreased as if they're experiencing decreased range of motion overall, and the strength of the fracture and like the surgery procedure that they went can all affect their ability to perform like like activities that demand strength. Um, Patients will often have decreased joint position sense or their sense of awareness of the wrist and hand in space, so proprioception. Decreased sensation is common. Patients can report feeling numbness or tingling around their hand near the fracture site. Um, and then patients will often report decreased use of their affected arm and hand. This one is one that I found that patients guarded their wrist and hand more often, the condition where they would most of the time try to keep that splint or orthosis on as long as they could. But you'll often see that like driving, eating with their hand, object manipulation, using it as a stabilizer, and then their ADLs can all be affected. The patient will also present with increased edema or swelling on the affected wrist and hand if it's non-conservative and they came into you recently or even after the surgery. If you think about it, surgery is kind of like how would you say it? It's another form of an injury essentially. Our body doesn't differentiate it. Essentially, like they're still cutting into your wrist and coming in and pinning and placing foreign objects into your wrist. So it's kind of going through that healing phase all over again. So even with the surgery, you'll see these deficits and see like edema and stiffness, etc. But measuring the circumference of the edema or using other techniques to measure inflammation in general and see how that's going on and progressing will be very useful. And then remember that symptoms don't only affect the limb directly, but they also contribute to other components of the patient's life. So sleep can be a huge one right here. Wearing an orthosis, feeling pain in your wrist can definitely cause you to lose sleep. Frustration due to decreased functional use, decreased independence, or increased dependence can all have a factor. And then again, mental health impacts or stress for many reasons. People use their hands for everything. I mean, it's kind of our the way we interact with the world, especially when it comes to work and getting paid and being able to live comfortably. So the inability to return to work, financial stress, caregiving roles, impacts on significant others, social isolation, transportation. These are all often affected. So keep that in mind when you're evaluating your patient, speaking with them, treating them. Just know that they're in a vulnerable state and you're in a seat where you can help them and guide them. And I mean, you're the knowledge holder here. So essentially they're kind of looking towards you to helping them get better, especially quickly, but you just gotta remember that healing time frames, meeting them where they're at, and just kind of going from there and using your best clinical judgment. Next, let's look at the relevant anatomy and physiology. So on a skeletal level, so the two images, one going over the terminology that is used to describe a fracture, and the second is showing you on a larger scale where the fracture site is and usually occurring at. So we can see the terms that we use are either extra or intra-articular and then displaced or non-displaced. So extra-articular is used when the fracture does not extend into the joint surface, and intra-articular does, as seen on the images on the right. The term non-displaced is used when the fracture causes a fragment of the bone to move in a way that is not in proper alignment. So as you can see on the bottom images, these are fragments on the radius bone where they're out of place, so to speak. Um, it's important to note that you'll often receive information on what the fracture is described as, or even sometimes receiving imaging from the hand surgeons prior to seeing your DRF patient. You'll find that most patients will likely want to show you the X-ray imaging that they have. And it can give you a good peace of mind as to like what is causing pain, or just kind of like help you piece like the pieces together, the puzzle pieces together, essentially. But again, on the image on the right, it's a more bigger picture of what the fracture usually occurs, and you can see that on the distal end of the radius, that's the location of the fracture. It'll cause the wrist and hand to become inflamed and in pain, reduce range of motion, etc. Um, but also keep in mind that it can affect the digits as well. Like I said in this video, I'll probably say it again in other videos, the upper extremity is a small space with a lot of structures. So oftentimes when you injure one part of it, there's multiple things that are being affected as well. Other like on a skeletal level, on a muscle level, tendon level, they're just all so close together that it's not just going to be an isolated one injury kind of thing. You'll see multiple things occurring when you see your patient coming into you. So let's look at bone healing because it's definitely important when we're talking about a fracture and treating them. So we have the different types of phases. So in the inflammation phase, this stage lasts for about a week, where inflammation kicks in and blood clots and hematomas form. This is for post injury and also post surgery. The inflammatory cells are released to clean up the debris, and growth factors are released to stimulate the bone repair. And then this stage really just sets the tone for the following phases of healing. It's kind of that foundational phase. Next, you have the formation of soft callus. It occurs often within the first few weeks, and this phase is a temporary framework. Is like the temporary framework is being built essentially from cartilage and connective tissues around the fracture site. So in this phase specifically, the bone is still not strong enough for strengthening activities or weight-bearing activities. You're kind of still kind of setting the tone for it to become stronger and creating that formation of hard callus. So in that formation of hard callus, this is where mineralization occurs. So we have the osteoblasts, so the cells that form bones. They deposit new bone tissue and then are hardened through deposition. So this occurs usually 2 to 4 weeks after the fracture and goes on for several weeks after that as it begins to fully harden. And so in this phase, the bone is stronger than it is before, but it's still not considered to be normal or mature in a way. We move into the remodeling phase, which is the final stage of bone healing. So the hard callus is reshaped and refined, and this takes months to even years to fully complete. And then factors like age, activity level, severity of the fracture can all affect the time for this phase to be completed. Um, a thing I'll plug in here is like Wolff's Law, as you probably read about it before, but essentially that bone adapts to the loads under in which it is placed. So it's important to note that there is a time during healing process where external forces and strengthening activities are appropriate and also sometimes contraindicated. But when they are allowed, external forces like those from weight bearing, manual loading, resistance training, functional hand use can all act as like mechanical stimuli that signal the bone to remodel in a way that you want it to. So there is a, so to say, just right touch to therapy where you're trying to find the way to load the bone and strengthen to allow it to properly remodel as if an individual um, is trying to get it back to where it is. So if you are, for example, guarding it and not using it as much, then the loading decreases, the bone can become weaker through resorption, and it's not going to be remodeled in the way that you might want to. But this really poses a challenge at times with patients who might feel that they need to wear their orthosis longer than prescribed or are hesitant to participate or transition into strength training. But just keep that in mind, reassure to them that usually past that like 8 week mark, we can start introducing some gradual graded strengthening activities. And you can even pull out imaging, examples, literature, experience, bring in your CI if you need to. But just kind of reassure them that like they're in a safe spot, usually at that 8 week mark, but we're going to grade it and we're going to work gradually. But anytime before that, it is contraindicated to perform strengthening activities unless it was a surgery condition. And this has happened before where the surgeon comes back and says, I am very proud of my work, nothing's going to happen here. We can start graded strengthening activities prior to the 8 week mark. But that's not something you want to make your own call on. Speak with your CI if you feel like you can be progressing sooner than that. Um, but definitely something that's happened before. Next, let's look at into the evaluation. So when and how, we're going to kind of follow along through here. So knowing when the injury occurred and if surgical procedures took place will be very useful in knowing the patient's timeline for therapy. So following the stages of healing will be important to ensure the patient heals properly, does not overdo it in the beginning stages. Following a protocol for certain procedures or types of injuries can be useful. It may also be provided to you by the referring hand surgeon too. They'll sometimes just plug that into the referral note. Knowing how the injury took place is also important. Understanding if the patient is at fall risk, if they have fallen frequently, or they're performing tasks or specific activities that may need to be adjusted or modified for safety. So just really knowing how it happened, if it's happened multiple times, is very useful, especially when it comes to planning for return to function planning and considering their work demands, hobbies, roles they hold in life. Next, knowing if the injury was handled surgically or non-surgically. This will give you a better idea of knowing for the timeline, because if the injury occurred but they had a surgery, you're going to use that surgery date as essentially day zero. Um, for when it comes to treating and knowing when you want to progress into like active range of motion, passive range of motion, strengthening, etc. Relevant medical history is useful to understand any conditions that may affect their healing or should be considered during therapy. Assessing if the patient's symptoms and how they feel is really important to plan for future sessions and kind of create realistic goals that will drive the therapy. Again, the quick dash, very powerful tool to understand how functionally they're being affected on a day-to-day basis. Initially, even after the injury, if it's treated conservatively or non-conservatively, grip strength will initially be contraindicated in the beginning phases of therapy. However, oftentimes um, you can kind of get around that if the surgeon, like I said, is very confident in their work and they say so, or your CI says so. But really, kind of like after that 8th week is when we want to start introducing strengthening activities. So let's look into treatment. So here I just kind of have an example of a protocols. So on the left, we have the conservative one. So they're pulled from two different protocol books that were recommended to me. Um, I'll plug them in into the module of what these resources are, but essentially conservative approach in this instance is a non-surgical one. You'll likely read this in your notes prior to having your patient arrive. If not, you can always ask the patient in your evaluation. But 0 to 6 weeks, active range of motion, active assisted range of motion. If the wrist, forearm, elbow, and shoulder are all okay, passive range of motion, and active assisted range of motion of the digits are okay. Once you get into that 6 to 8 weeks, that's where passive range of motion of the wrist specifically can be initiated. I mean, that's where that fracture site occurred. We want to give it a little bit more time based on the healing time frames to kind of get a little stronger before we start applying pressure onto it. And then again, at 8 weeks plus, the bone is healed at this point. Gradual strengthening may begin. And if we look on the right, compare it to the ORIF um, protocol, it just looks a little different. There's some extra steps in terms of progression. Again, if the hand surgeon who's referred your patient has a different plan in mind and they plug it in, feel free to follow that. But just kind of an idea to consider when it comes to performing treatment activities. Here we have kind of like the most common orthosis that's used. When it comes to wrist immobilization following a DRF, your patient may come into the evaluation already with one made, or perhaps they'll be wearing a prefabricated one. Remember that these kind of are one size fits most. So sometimes you might ask them whether or not they feel it's supporting them, it's comfortable or not, and you might go on and make a custom orthosis for them out of like thermoplastic. But essentially this is kind of like a common way to go for it. You're essentially immobilizing the wrist, but allowing the digits to remain mobile. So that way they can still use their hand. Because again, if you were to immobilize more joints that are necessary, chances are your patient's not going to want to wear it because they're not going to be able to do the things. It's going to be cumbersome. It's going to be bulky. So just keep that in mind when it comes to creating one. And it'd be really beneficial to get practice in school or leading up into your clinical rotation with your CI if you get the chance. Lastly, treatment section. So this is not a list of everything you should do and definitely not in any particular order. However, I'm going to list a few things kind of just as ideas of what you can do. And I've categorized them based on the types of movement and kind of phase. So I'll highlight some of these, but I'll try not to be too repetitive. But so like active range of motion is seen as a huge focus, especially early on in the patient's recovery timeline. So I think an important thing to note here is that you can still use functional activity in this early phase. So object manipulation, fine motor tasks are a great way to encourage early movement without any resistance and can have the patient feeling that they're doing something when they come in to see you. I found that long wrist extensor gliding, tendon glides, wrist tenodesis coupled with like instrument assisted soft tissue massage can help break down those tissue adherences that we see over the fracture or injury or surgery site. So just kind of keep in mind to not apply too much pressure as early on they will feel tender. They may not like it. They will definitely tell you if they don't like it. But it's always good to not be too tough, but still kind of get in there and break up those adhesions. A trick that I came up, well, I wouldn't say came up with, but a trick that I saw is that when you're performing these and doing instrument assisted soft tissue massaging, kind of get a look at their face. Most patients are going to want to be tough and they think it's a no pain, no gain mindset, but you can tell a lot by their face. If they're grimacing, closing their eyes, you might be overdoing it. That's when you just ease it up a bit. Moving on is passive range of motion, something that will be appropriate later on in the healing timeline. And in this section, I'd like to highlight the introduction of light joint mobilizations to help restore joint mobility and facilitate some early mobilization. So you can like break down adhesions and improve the gliding of the joint surfaces manually with a solid understanding of the joint kinematics. There's multiple ways to approach this, but you really are just going to have to do a little bit of studying and practicing with your clinical instructor to kind of really get this down. But I'll likely attach a video of me performing two different types of joint mobs that I've used in my clinical rotation. But again, before attempting them on a patient, be sure to practice with your CI and ask for their guidance, their tips, their tricks, so that when you perform this on a patient, you're not causing them any harm. Active assist is one you can really get creative with. So like early on, rolling the palm on the affected hand over gently on a ball on a table is a great way to self-facilitate wrist flexion and extension. Can be great for an HEP when sending someone home after an initial eval. Some of these will be very appropriate early on. Some of these will be best to wait to utilize once resistance can be used, such as like using the weight of the hammer to facilitate pronation and supination. You can still use something lighter and use something with like a long like a long arm essentially to kind of help guide that motion and pronation and supination. But again, when it comes to like heavy weight, like the head of a hammer, it's best to wait a little later. Lastly, strengthening. This is where the patient begins to get very excited and usually looks forward to because it feels like they're doing something and they're in their home stretch now. So oftentimes you'll see they might be eager this phase, especially within the first couple of weeks. But it's remember to just kind of follow those healing time frames, telling we will get to it, just not quite. We want to make sure we decrease the chance of re-injury and just make sure that we are progressing at a safe pace. Um, so one last thing that I didn't add on this slide is that's really beneficial to look at is proprioceptive activities. These are all fair game throughout the entire healing process. So you can use like a true balance tool. I'll have a video of me using it. I'm not very good at it, but I'll have a video of me doing it. But essentially joint position sense is really um, a good way to kind of add some like activities into a daily routine with them, especially when you're coming into your therapy clinic. But there's different ways you can do this with like different joint position sense testings, true balance activities, rolling a marble on a frisbee, kind of getting it to spin one direction and another. You could probably even get apps on your phone or an iPad and do like those mazes that you kind of like roll the ball around based on how you move the iPad with your wrists. But just take note that proprioceptive abilities honestly drastically decrease as we become fatigued. So keep that in mind whether you want to challenge your patient more or less. If you want to challenge them more and you think mentally they're up for it, you can give them a proprioceptive activity towards the end of treatment once they've become fatigued after activity. Or if you're feeling that that might frustrate them or might be too difficult, you can do it at the beginning of the treatment session. But that's really based on your own clinical judgment, based on who they are, where they are, and what it is you want them to be doing and working on. But I believe I have another, I think there's actually a really great podcast about proprioception and distal radius fracture that I found very interesting. I'll plug it in. You can listen at it a little bit faster than one-time speed, but definitely beneficial and one of the rabbit holes that you can fall into when it comes to distal radius fracture. But again, this was a little crash course, kind of an introduction, not necessarily a in-depth presentation on exactly what you should do step by step, as they are not cookie cutter conditions. But this is just kind of get the ball rolling. But thanks for listening, and I look forward to the next module.